Welcome here to the Institut Cardiovasculaire Paris Sud. My name's Tom Johnson, and it is a great pleasure, a true honor, to be here this evening with you to discuss a complex high bleeding risk patient in the context of this series of PCR webinars very kindly supported by Terumo. So you'll have seen that the purpose of this afternoon is to look at the management of an HBR high bleeding risk patient with a bifurcation lesion. And clearly it makes great sense to be here in Massy with Thierry Lefevre and Bernard Chevalier, really to make use of their great expertise and understanding of bifurcation strategies. So if we could move across to the slides. So this is set within the context of a webinar that was held earlier in the summer in Toulouse with Jean Fagedet and Bruno Farah, compared by Jim Nolan. And the purpose of that was to really look at high bleeding risk elements to a complex case, but primarily dwelling upon the issues of vascular access, the benefit of radial versus femoral approach. As I say, today is based upon the use of decision-making in complex PCI, so particularly bifurcation strategies. And then later this year, with Tom Arquise, who's been the coordinator of this series, he'll be meeting with Marco Valgamigli and Peter Smits, the co-PIs for the MasterDAPT high bleeding risk study. So our learning objectives this afternoon are firstly to consider really the high bleeding risk characteristics of a patient and potentially to discuss the role of scoring patients for our decision making. Really the focus within the cath lab, I think, is going to be looking at technical challenges, considering the choices that we make regarding bifurcation strategy in a high bleeding risk patient. And then lastly, I think we need to consider the pharmacology and particularly in this case to consider the complexities of decision making we have with patients presenting with atrial fibrillation who require PCI. So if we look at the case that we're going to be treating this afternoon, Mr. D is a 74-year-old gentleman who presents with a 3-year history of breathlessness on moderate exercise, and over the last 6 months his symptoms have deteriorated significantly. I've already alluded to the fact there's a past history of atrial fibrillation, and he's currently taking apixaban 5 milligrams BD for this. His risk factors include dyslipidemia, an elevated body mass index, and hypertension. This is the ECG confirming atrial fibrillation. And the first investigation that was undertaken by the cardiovascular team was a multi-slice CT undertaken in August, which confirmed long and calcified, potentially significant stenosis within the mid-LAD. And so the patient was brought forward for a diagnostic coronary angiogram. And here we see the left coronary angio, which in this caudal projection shows a severe stenosis, in fact, within the circumflex artery. And then we come up into this ariocaudal projection, which I think is most important for delineating the LAD disease. And here we see a very significant lesion in the mid-LAD, distal to a large diagonal branch, which also appears to have some disease within it. The cranial projection again confirms the severity of the disease within the LAD, really just reiterating the information given by the CT scan. And here we can see relative preservation of the proximal limb of the LAD. The right coronary is dominant and without any significant focal disease, as seen in these two projections. So the procedural strategy from the group here in Paris is for a planned transradial intervention, both treating the mid-LAD and the mid-LAD bifurcation lesion. And the purpose is to introduce this patient to dual antiplatelet therapy in the context of his apixaban for atrial fibrillation. And the hope is that this patient will be randomized into the MasterDAPT study, which I'm sure we'll discuss a little later on. So I'll just take ourselves back to the areocranial projection and just see whether there's any discussion yet within the discussant group maybe to consider the complexities of this intervention. So we really want this to be a very interactive session, and so please do feel free to give us your comment, to ask any questions that we can hopefully then address across this 90-minute period. For me, I think the most important issue here is calcification, which may not actually project brilliantly on this angiographic image on the PowerPoint, but hopefully with the projection from the cath lab, we may see that there certainly is quite significant calcification. And so that is clearly going to influence our decision making and also the strategy during the procedure. So maybe we'll hand over to Thierry and Bernard in the cath lab now, just to talk through their strategy today. Thierry, Bernard.
Thank you very much, Tom. I think it was a very nice introduction. As you've seen, this patient is relatively complex with high bleeding risk and this bifurcation lesion with some calcification. And this circ also, which is a focal lesion, but also a little bit calcified. So our strategy in this case will be to wire both branches. So we have a transradial approach, 6 French, with an extra backup 3.75. We will wire both branches. And then because this lesion is 0.10 lesion, or maybe 0.5 for the side branch.
Yeah.
And so we'll predilate with a non-compliant balloon and going to high pressure. And if we are not able to open the lesion with a non-compliant balloon, we'll switch to rotablation. Okay. I think it's very important because the final objective is really to obtain an optimal deployment of the stent, which is even more important in this patient with high bleeding risk, because we'll want to have relatively short duration of DAPT or even triple therapy. So Bernard is wiring the diagonal branch with this with a run-through wire, as you can see very nicely. Then we'll wire the LED.
So your intention here is a provisional approach, clearly, to try and keep things straightforward.
So optimal deployment of the stent, and if possible, use only one stent. So it's a really a provisional side branch stenting approach.
Yeah. So we've also already had a couple of questions from the audience. One very reasonable one, which I have to say crossed my mind, was, does the multi-slice CT give you any understanding of the calcium, the nature of the calcium or the location of the calcium in relation to the bifurcation?
Yeah, it's a good point. So by MSCT, calcium was not so much important. So that's why we decide to start without rotablation. But of course, if we see that the balloon will not expand correctly, we'll have to switch.
Okay, so that answers Bogdan's question as well. I think there's certainly someone in the group who thinks they might rotor up front. So clearly, I guess that comes down to the interpretation of the initial angiogram. But you're planning to palpate the lesion first, and then if needs be, kind of escalate to rotablation.
Yeah, absolutely. Okay. Yeah.
Good.
So you can see that now Bernard is coming with another run-through wire in the LED, with a nice wiring. And of course, our nurse will take care of these 2 wires, which are on the table as they are on the screen. So you will have the LED just here and the diagonal here. Okay. It's very useful because you always have the information which wire is which one. So now we have a 225 non-compliant balloon, AccuForce. So you can go to very high pressure with this balloon. Of course, it's not ultra high pressure, but you can go to 18, 20 without any problem.
Good.
And we'll see if we are able to open this lesion or not.
So another consideration here has been whether you'd use FFR up front to make an assessment of the severity of that diagonal lesion. So some in the audience have already highlighted they'd give it probably more than 0.1, 0.5, and maybe 0.11. So
Yeah,
if we
okay.
used FFR to define the severity, then perhaps we have to shift to a 2-stent technique. That's another consideration. But I think, Thierry, we're agreed that ideally for the purpose of limiting this patient's bleeding risk, we want to keep the stenting strategy as simple as possible.
Yeah, absolutely. So of course, I think FFR is a very good option. If we have some doubt, we'll use FFR. For the LED lesion, we had no doubt that this lesion was really significant. It was significant on MSCT and angiogram, so there is no doubt about that.
Yeah.
So now we have the 225/15 in place, non-compliant balloon, and Bernard will go to.
Well, I have to say the multi-slice CT, using the multi-slice CT to guide decision making is an interesting one, and we're taking a particular interest in calcium now with the arrival of new adjunctive technologies. And I'd just be slightly fearful that the blooming artifact of a CT will certainly overcall the extent of calcium.
Yeah, it's a good point. Yeah.
And won't necessarily be able to tell you whether it's true luminal or deep calcium as well. So I think there are a number of considerations there that we'd take into account. So that balloon's coming up.
Yes,
we're just slightly distal to the bifurcation, aren't we?
Crossing the balloon was not so easy.
Mm-hmm.
You have to use a little bit of intubation from the guiding catheter, so it must mean that it's really more calcified than it looks. Okay, yeah. So we are in place. I think we are just going to make a small test to check the position. Test.
Okay, so it looks perfect.
Okay, inflation. So we'll inflate.
So you see the waist on the balloon.
Yeah.
And now it's opening.
14.
It's clearly a very calcified lesion, isn't it?
Yeah. Can go to 16. Okay. So very nice. So 16 atmosphere is a reasonable pressure. So it's good news.
Okay. So that appears to have inflated, yeah. So you're going to come slightly more proximal just to treat across the level of the bifurcation?
Yeah, of course, yeah.
For sure.
So I have to say, with our practice now having lithotripsy as well as rotablation, we're increasingly undertaking intravascular imaging here. Now, you've shown beautifully how that lesion appears to have modified with ballooning. What's interesting is to understand whether you've got deep or superficial calcium in terms of which modality you might take, rotablation or IVL, although I think it's not relevant to this discussion now that we've seen the plaque modify. But yeah, I think imaging plays an important role in us understanding the extent of calcium.
Yeah, I think I really think that it can help to take a good decision before going into one or the other direction, rotablation or non-compliant balloon. So maybe 16 again, yeah.
So we were talking about keeping a simple strategy of single stent provisional. How long are you anticipating this single stent to be? So have you got clear landing zones?
Yeah, so we plan to use 28. So maybe we can use a balloon to check that 28 will be the right. So
that's come up very nicely, hasn't it?
Yeah. So the balloon is 15, so 15 plus 13. Vas-y, monte encore, parce que monte à 18. Ouais. Okay, so we can clearly see that the balloon is well open too.
Okay.
So Bernard, 28 for you will be the...
I think we need to check again with a balloon deflated.
Okay.
We know that this one is 15 millimeter long.
Yeah.
And so clearly your decision making in terms of stent length is based partly on healthy landing zones, but then in terms of the bifurcation strategy, are there particular issues that you want to bear in mind for stent length?
Yeah, of course we want to be in a good landing zone, proximal and distal, and we can use the balloon to measure the length. We know that between the two markers we have 15 millimeters.
Yeah.
So maybe it will be a little bit short, no? What do you think, Bernard?
28?
Yeah.
I think it's.
Or
It depends where you want to land. I think we can just.
yeah.
Do you consider the proximal marker is in the right position, or?
Yes, I think so. Of course, we can go back to more proximal, but it will be proximal to the first small diagonal branch.
Yeah.
And then you will need a 33. So I think 28 can be a good start, I think. No?
You certainly want to come. You certainly want to be around that bend, don't you? Often the problem of landing onto a bend is that kind of beaking type appearance that you get following stent deployment. So I guess you have to treat fairly distal to avoid that angiographic appearance. My personal preference would be to come back into as healthy a segment as possible in the LAD, but that's going to make it quite a long stent.
Yeah.
I know Bernard is keen to reduce the length of stent as much as possible to reduce
exactly.
the
So
thrombotic risk long term.
Exactly. So we have to find the right balance between optimal scaffolding and low risk of stent thrombosis.
Yeah.
So Bernard?
I will give it 28, I think.
28, okay.
Yeah.
Okay. So we have selected a 2.5 28.
So we have a couple of questions regarding the pharmacology. So has the patient been preloaded with 300 of clopidogrel? And if so, when?
Yeah, so very good question. So we the coronary angiogram was done 10 days before.
Yeah.
So we decided not to give a loading dose, but just start Plavix and aspirin on top of anticoagulation with a conventional dose, because we had time to have a full anticoagulation. Of course, if we had to do the case 2 days later, then I think it's better to give a loading dose. But of course, by doing a loading dose, you may increase a little bit the risk.
Yeah.
What is nice in this kind of patient, I like to take time in order to be sure that we not have bleeding before starting the double antiplatelet treatment and doing the procedure. So I think having 10 days before is very nice, because sometimes you discover that you have done the procedure, and then 2 days or 3 days later the patient is bleeding from the colon or something. So I think it's nice to take time and to start the loading dose, the treatment in advance.
Good. Okay. I'd agree. I think there's very little risk of precipitating bleed by loading dose, but 10 days up front, 75 milligrams will be worthwhile. There's another question about, obviously you've gone transradial, but what's your peri-procedural antithrombotic regime? So what are you using in the cath lab? Heparin?
Yes. Yeah, so the patient is on top of heparin. He had 80 milligrams of heparin at the beginning of the procedure.
What, that's 70 units per kilo, or?
Yes, in this case it was 80. We have given 5,000 units in the transradial sheath and 3,000 intravenously by the anesthetist. And we have checked ACT, and ACT, c'était combien l'ACT? Maud?
It was not working properly, so we are
okay, so ACT is more than 300.
Draw again a new one.
And we do another one, yeah, okay.
And do you have a routine for when that ACT will be taken?
Yes. Systematically in all
we do always ACT for all cases.
All PCI, all structural cases.
Okay, yes, so now, certainly in our cath lab we'd have a stop clock, and we would be informed 15 minutes into the procedure to take an ACT and continue measuring throughout a long procedure. So it's a worthwhile consideration.
Yeah. So now Bernard is placing the stent. So 2.5 28 Ultimaster.
Maybe it's a little bit too distant.
Yeah, probably you can pull back a little bit, probably.
So just
And then
another of the
we'll-
considerations here is the proximal landing zone, but having enough room for a pot, isn't it, in terms of
Yes,
the
absolutely.
placement of the bifurcation?
Yeah, so this is also very important. So we have planned to do a pot with a 3O balloon, and the minimum length that we have is 8. So we need at least 8 millimeter proximal to the carena of this bifurcation.
Okay.
Okay, I suggest to check this position.
Yeah. I think we have some room to pull back a little bit more, no?
You want to be back? That means that you are going to cover the first diagonal branch.
Yeah.
I'm not sure we need to do that. I think we are covering the distal plaque,
Yeah.
which is just few millimeters.
Yeah, distal plaque is perfect.
Apart the distal marker. We have enough room to place a pot balloon.
Okay. So I think what we can do is to have the marker of the balloon in front of the diagonal, because the stent is more distal to that.
Yes. But it's okay.
It's quite,
it's,
1 millimeter.
Half millimeter.
Half millimeter maybe.
It's
So we try
precision,
to be-
precision PCI and massive.
Yeah, we try.
Okay. I check again.
But that's another really
Yeah.
great point, Thierry, that
Yeah.
the stents do fall within the balloon marker for the majority of the companies, and it's important to
absolutely.
understand exactly where that stent is in relation to osteal disease, or in this precision placement for bifurcation as well.
So Bernard, you like this position?
Yes, I like this
Okay.
position.
Good. Okay.
Tom, do you like this
I love it,
position?
but I think it's brilliant.
Thank you.
Okay.
Okay, let's go. On va à 12. So we go to 12 atmospheres.
Okay. So this is a 2.528. We are going to 12. So deployment of a stent distal to the bifurcation. Proximally, we can see that there is some resistance. Huh?
Yes, clearly there is some resistance.
But of course, we'll do the pot and we'll be able to go to higher pressure with a non-compliant balloon.
14.
So we have someone clearly in favor here of imaging who's suggesting that they would IVUS before undertaking the pot.
Yeah.
So I mean, clearly you're making an
Yes,
angiographic assessment of the proximal vessel caliber. So you're happy 3.0 will be sufficient to achieve apposition.
Yeah.
Okay, we are now at 16 atmospheres, which is the RBP for
Okay.
the
Of course, this is
tensile we placed.
This is a very complex question because by IVUS, as you know, you have some compensatory enlargement, a Glagoff effect.
Yeah.
So how to measure the correct length, the correct size? Media to media, lumen to lumen, in between. So we prefer to calculate the size according to the reference of the LED distal to the bifurcation and reference of the diagonal in a normal vessel. Of course, sometimes you have no normal vessel. And of course, we like also to do a stent enhancement.
Yeah.
And you will see now, okay, so we have stent enhancement and we can see clearly that distally it's okay, but proximal to the bifurcation, the stent is not open.
No. And that was evident, in fact, with the balloon inflated, wasn't it? It looked slightly underexpanded in that proximal segment.
Yeah, despite 16 atmospheres. So we'll go to we'll do the pot, and probably we'll have to go to higher pressure.
Yeah. Okay. I mean, I think it's quite interesting that when you do image these, often you're surprised by how much bigger the proximal vessel is than you've made in the judgment angiographically. So I agree there's a difficulty of interpretation in terms of the inherent oversizing that IVUS gives against angio, but in fact we do find often that the vessel is larger. But 3.0 here certainly looks very appropriate. I mean, clearly
yeah.
there's already been a trade-off in terms of the proximal landing is into a slightly diseased segment, but the purpose of that is to limit your stent length so that in the long term, the patient is at a lesser risk of stent thrombosis, which
Yeah,
I think is very reasonable.
Ok, donc 3-0. On peut avoir le 3-0 NC, s'il te plaît? So now Bernard will do proximal optimization with a 3-0 non-compliant. So you can see that the stent was 2.5. So I think distal to the carina, we have a correct size.
Okay.
So 2.5. Diagonal is a little bit smaller, so maybe 2.25. So if you make the calculation according to the Finet's law,
Yep.
it will be 475 multiplied by 2. It's 9.5, and divide by 3, it's 3.15.
Yeah.
17. So I think a 3.0 at high pressure will be the good size.
Yeah,
So
very
for
reasonable.
example, this AccuForce 3.0 at 20 atmosphere, it will be 3.15.
Okay. I thought you were just wandering across to a calculator there, Thierry. I was about to be impressed that that was used. So there's another couple of questions. Before post-dilatation, what about the side branch rewiring to prevent the jailed side? Are we worried about the jailed wire? So is that something that we're happy to?
It's a very good point. We are not worried about the gel wire because it's not really gelled. The stent is not well open, and we have a very short distance of stent. So it's preferable to not to remove the wire because the wire will help you during the procedure. So we'll take time to position the balloon for the optimal pot. So just at the level of the carina, so just proximal to the carina. And then we go to high pressure, and this will facilitate access toward the diagonal branch.
Okay. So talk us through what you're doing if you can here. So obviously you're going to use the stent V's again, are you at this point?
Yes, I think it's very important to use stent V's in this point, but to be sure that you are not outside.
Yeah.
Okay. So I mean, clearly here we have the most fantastic calcium, don't we, within the diagonal bifurcation, which shows us the side branch, but it's actually a really nice demonstration of how the side branch wire mustn't be used as your guide to where the carina is, because obviously that's jailed and trapped against the outer wall, so is in fact much more proximal than the true carina. Is that fair to say on the interpretation?
Yeah, absolutely. So so the proximal part of the balloon is just at the entry of the stent.
Yeah.
So we can go to 18, I think.
And then you're going to move forwards onto the carina for a second inflation, is that right?
So you can see that now we have opened the stent. I think it's clearly better. And we'll do another stent enhancement, Bernard, maybe.
Yes, I think so. Yes,
just to show to the audience that the stent now is open.
And also to be sure we are not missing the first strut of the stent.
Absolutely.
Because we see clearly the bifurcation of the carina on this stent V's, but not very well the proximal part of the stent. Off, yes.
Okay.
So we do usually relatively long inflation. I don't know if it's very long, but we do 30 seconds at least.
Yeah, I think it's also very important to do long inflation when you deploy the stent because time is your friend.
Yeah.
And by time you increase the size of the stent. So, so Bernard, you push a little bit more to be at the level of the carina. Yeah.
Yes, I want first to pull a little bit more. To be sure with the stent V's that I'm not missing the proximal part. Okay.
So we can do another stent V's?
Yes, that's what we're trying to do.
So obviously this is a beautiful example with the calcium within the bifurcation, but if we were in a non-calcified bifurcation, you'd be having to use contrast, I assume, for this in terms of then understanding the placement?
No, usually we use stent enhancement for the placement. I think it's the best method to be sure that you are really at the right place. So you can see that now the stent is better open. It's not perfect.
You can see that the very proximal part of the stent was not fully open because it was not at the level of the balloon. So we are going to make a new one, new pot.
And maybe you can go to a little bit more higher pressure.
Yes, we go to 20.
Okay. So you, by doing that, you decrease the amount of contrast that you are using also. I think it's an important point. And so stent enhancement is very useful technique. Of course, for people who are using intracoronary imaging, probably they don't need stent enhancement or less. But if you use not too much coronary imaging, stent enhancement is really a very useful tool.
No, very. I think it's complementary, Thierry. To be honest, I think you use everything available to you. So here now, in terms of the pot placement, you're placing that distal marker of the balloon onto the carina. Have we done that yet? That was the last balloon inflation, was it?
Another stent enhancement to check that the stent is well open. I think it's really better.
Okay. I think it's okay.
So now what we can do, maybe go more distal to be sure that we are really at the level of the carina.
So we have a question particularly pertinent at this point about, are we opening the struts into the diagonal? I think you've already highlighted that, Thierry, that the pot has two potential benefits. Obviously, we've seen already that the stent is underexpanded in the proximal limb. So it's really important that we adequately expand the stent and prevent, if we have to rewiring behind the stent itself. And then this pot inflation that we have being undertaken right now will preference the struts opening across the side branch and hopefully open up the ostium, making rewiring much more straightforward should we need to. So there are two benefits of the pot.
Yeah, absolutely. And it really facilitates access toward the side branch, especially the distal strut. So it's there is on pot is really your friend now. So clearly.
Yeah.
Okay, so now we have done post-dilatation just proximal to the carina. Usually it increases the size of the strut in front of the side branch, which is also very important. And sometimes you may have very good result even by intracoronary imaging just by doing the pot.
Yeah. And then it's the intention to post-dilate the more distal limb second.
Okay. So Bernard, what will be the next step?
I think the next step is to give a little bit of nitrate and to check the angio.
Okay.
I think what we have seen just before, it's indicating some worsening at the ostium of the side branch. So
yeah, some worsening, I fully agree.
Probably the question of the kissing balloon.
Yeah, some carina shifting, I think.
Will be easy to answer.
So you wouldn't routinely kiss?
It's really on demand.
Yeah, I think there is many options in this case. Keep it open, which is the case. In this case, the side branch is relatively big, so we have to find the right balance between the risk of putting two stents in this case. But I'm not sure that by doing pot side pot to pot kiss pot, we'll increase the risk of needing a stent in the side branch.
Okay.
So if we do kissing, the main reason is just to relocate the carina at the right place, so in the middle.
Although we see there now that the pot has really nicely opened up the proximal limb of the stent, hasn't it, into the bifurcation?
Yeah, absolutely. So now we have really a stent which is nicely open with a correct size proximal to the bifurcation, correct size distal to the bifurcation. And then the question is, should we do something to the side branch?
Yeah.
So Bernard, what is your opinion?
I think it's a relatively large diagonal, so
Mhm.
it's an argument to do something. We have also to be clear that if you look at what we had before, there is some disease,
Mhm.
and we create a risk of putting a second stent if we do kissing balloon in this situation. So it's not a decision, I think, particularly for this kind of HBR patient.
Yeah.
I don't know if you have some feedback from the attendees.
Well, it's
about
interesting.
this
We had
situation.
that question about FFR pre-stenting. You could argue that you could FFR
Yeah.
post-stenting. I guess that the difficulty here is that you are very keen not to intervene on the diagonal. So that in many ways then influences the decision making. So it would be reasonable to assess ischemic burden in the diagonal branch, but if the trade-off is that you really want to do everything possible to prevent complex two stent bifurcation, then probably you accept this as a very reasonable result, I imagine. It's the context, isn't it?
Yeah. So I think FFR can be also a good option in this case.
Yeah. So we have a question about, is there a dissection at the diagonal ostium? I guess that leads on to what features angiographically are going to push you definitely to have to intervene on the diagonal branch. So clearly if there was a dissection present, that is going to push towards having to do something. Is there anything else in terms of the level of pinching or TIMI flow, or what else would you use?
Yeah. No, I think the first question is this side branch relevant?
Yeah.
I think so, because it's bigger than 2.25, or at least 2.25. It's quite unique diagonal branch. There is another one which is very small. And according to the work of Ku, we know that when there is a diagonal branch, only one diagonal branch, or no diagonal branch below this one, it could be a good reason to consider that it's a relevant diagonal branch.
Yeah.
But it's open. So I think the question is now it's open. So the risk of periprocedural MI is very low now. So the question is, will this patient have ischemia related to this diagonal at follow-up?
Yeah.
Difficult to answer to this question. So FFR can be a good option before
Yes, it
doing
could be a
something
good
more,
option.
or doing kiss with a non-compliant balloon in side branch with a very short non-compliant balloon.
We'll take
Shall,
another view.
shall we put it to a vote? We could vote here.
Yeah.
Yes,
Okay.
I think so.
Who will do something more to the diagonal? Yes, or who would stop? No. So the vote is out at the moment in terms of diagonal intervention, yes or no. Yes to proceed, no to stop. I see that we've got
seen the importance of having an optimal view when you treat bifurcation lesions. So the view that we had since the beginning was perfect. You have a very nice separation of both branches.
Yeah.
So you can really assess the side branch. Of course, we have a tight stenosis at the ostium, which can be negative by FFR.
Yeah.
Clearly.
So votes-wise at the moment, I'm afraid it's 100% towards treating the diagonal, but the votes are limited, I have to say. So,
how many people?
Let's not expand on that. But I think you know I think it does come down to the context here, and this is, you know, in terms of bifurcation. I think if you took the bifurcation in isolation, then you probably would look to KISS and optimize. But if we're looking to simplify the intervention because of the high bleeding risk, and it's in a stable setting, then it would be very reasonable to be guided by patient symptoms and consider, you know, even staged intervention if it was needed to this diagonal branch. But
I agree.
I think it's very much tailored to the scenario.
Yeah. I think for this patient, the most important is to have a good result on the LED with a stent perfectly deployed and apposed with the right size, proximal and distal to bifurcation, to the bifurcation. Then
So
the
in fact,
diagonal,
actually,
But we can put it the other way around, meaning that if we are going to stop the aspirin maybe on the clopidogrel very soon, in the context of master DAP, particularly if the patient is randomized for abbreviated treatment, maybe the safety of leaving this tight stenosis on the diagonal is an issue. So it's to be honest, if I have to decide by my own, I will perform kissing.
Okay.
And what do you plan to?
I agree with you.
Yeah.
So you have a 50-50 split, actually. Lots of people didn't use the thumbs up voting. So we have a probably 50-50 split in terms of intervention to the diagonal. So I think that's very reasonable.
Non, mais c'est 38 là.
Okay. Yeah, so this is a kind of case where we are discussing. So we are not alone in the CAS lab. Of course, we are not working with two senior for this kind of case. But before taking the decision to do something more, we ask outside another senior guy to come and discuss what should we do in this particular case.
Yeah.
Of course, this is in the context of high bleeding risk patients.
Yeah.
So it's a little relatively special. Outside of this context, I think probably we'll do a kiss in this patient. So as you can see, as you can see, Bernard is going back with a LED wire. Okay, you are just enter. You see, so pulling the pullback technique is very useful.
Yeah. And so you're preferencing a distal cell cross ideally here, Bernard?
Yeah,
yes, we try to do that.
Okay.
Okay, so you see he has already crossed. So this is the best technique to go in the side branch is doing the pullback technique.
Okay.
So this is a wire which was in the LED, so a run-through wire.
Yeah.
And now Bernard will pull back the gel wire, taking care of the guiding catheter. Of course, this is very important.
Yes.
And put in the LED, and then we'll do the kiss. So what we can use is, on va prendre un 2,25/8 NC. So we'll take a 2.225 8 mm non-compliant balloon to open the strut toward the side branch.
Okay.
And do the kiss with another 2.5 balloon, now non-compliant or semi-compliant?
I think we can use a non-compliant.
Semi-compliant?
No,
non-compliant. Okay. Et on va prendre un 2,515 NC, non-compliant. Yeah.
So you're taking a non-compliant balloon to cross the side branch. So do you feel that the stent selection influences your ability to do that? So historically, the non-compliant balloons were fairly bulky and recrossing.
Yeah, but we have very good non-compliant balloons like Ultimaster balloon from Terumo.
Yeah.
And usually you don't need to, you are crossing the side branch in more than 90% of cases if you do a pot. So the most important is to have really a pot with a perfect opening of the side branch. Yeah. Okay. So now, yes. So because with the pot you really open the strut, so access toward the side branch is easy. So of course sometimes you will need to use a smaller balloon.
Yeah, and clearly this is an open cell design, so
absolutely.
The stent will open very nicely across that ostium, won't it?
Okay.
So we have another pertinent question which relates to, would we consider a drug-eluting balloon in the side branch in this setting? Obviously we're keen to avoid two stents, but is there a place for using a drug-eluting balloon as we have disease already apparent at the diagonal ostium?
Yeah.
What are your thoughts on that?
Yeah, we have not a lot of data about that. We have a feasibility study. We were participating on this study, which showed a very good result at
Yeah.
follow-up, but it was not randomized.
Okay.
I think we really need a randomized study because I'm not sure that we'll have better result as compared to a KISS with a non-compliant balloon.
Yeah.
Okay, so ion gel the diagonal wire.
So
Gel
maybe
wire.
you have seen Bernard taking care of the guiding catheter. So when you pull back the gel wire, you may engage the guiding catheter just by aspiration. So it's very important to use what we call the
Sur
left
la
hand
diagonale.
control
Ouais, ouais, pour
Yeah.
y
to be
aller.
sure that you will not damage the left main or the proximal LED. Okay, so now Bernard is using this wire to rewire the LED.
So obviously the benefit of having used the LAD wire to wire the side branch is that you can be very confident you're not going to go under a strut in the proximal vessel.
Yeah.
But
But it
now
is
obviously
also,
this wire passage, there is the potential risk, although the pot will have minimized that chance substantially,
exactly.
I guess. Yeah.
So I think this is the beauty of the pot is that at the same time you prevent this kind of problem.
Yeah.
Okay.
By
On a
having a
linéaire, là.
perfect apposition of the stent proximal to the carena.
Hein?
Okay, so
And
now Bernard is using the 225 balloon, non-compliant, to go in the diagonal. We'll see if we are crossing or not.
It's not an easy crossing because I feel I felt some friction,
resistance.
yes,
Okay.
when I was going with the wire. So
okay.
I won't be surprised if I fail to cross.
Okay, not.
So would you simply look to recross or would you anchor? What are your options or thoughts now?
One of the options is to do anchoring balloon in the LED.
Yeah.
When you try to recross, but Bernard prefer to pull back the balloon. So you want to use a smaller balloon, Bernard?
Yes,
1.5 or 2?
Open with, I think 125 is.
125?
Yeah, 125 Uray is.
Ok, un Riuret 1.25 mode. So we'll predilate with a small balloon.
Yeah. So obviously, I mean, we've talked about the preferential reopening of the stent and that we're using very open cell designs, but it is possible that you've got a very small kind of opening around struts at the distal ostium, isn't it? That actually you may need to come more proximal in order to deliver devices. It's going to very much depend on the way in which the stent has fallen across the ostium, I imagine.
Yeah, of course. And of course, in this case, it's there is a lot of calcification, so it's not very helpful.
Yeah. So there are a number of questions about this decision making around the side branch, and I guess it's important just to be clear that there are a number of elements to your decision, partly down to the territory at jeopardy, and we agreed that the diagonal was a large and very worthwhile territory. The degree of pinching of the ostium, that then there would also be an issue about whether there was evidence of a loss of flow or evidence of dissection. So I guess the historical trials, so BBC or Nordic trials, used either a loss of TIMI flow or evidence of dissection, or in fact marked pinching, 90% or more pinching as their kind of trigger for doing something in the side branch. That's fair to say, isn't it? That they're the sort of triggers that we would use for decision making here.
Yeah, absolutely. So you can see that the 125 was able to cross relatively easily.
Great.
Okay, so we went to 16 atmosphere.
And now go back with the 2.25 AccuForce.
Absolutely.
Yes,
yeah.
That's what we plan to do, yes.
Okay. C'est l'autre. vais le brancher. Si tu veux.
And then in terms of your sizing of your kissing balloons, so you've already highlighted you're going to take a 2.25 and 2.5. So obviously you're taking those as direct kind of reference sizes for the distal branches of the bifurcation. And then you mentioned about pot side pot or pot kiss pot. So you're always going to then move back to proximal optimization, having undertaken this. Is that correct?
Yeah. So I think that sometimes we don't need to do a final pot if we have used a very short balloon and we have done kissing in the polygon of confluence, but not too much, not proximal. But of course, if you have long balloons, then it's better to end the procedure with a final pot to be sure that we have a really circular appearance of the proximal part of the bifurcation.
Okay.
So there is many options. One is, so you see now the balloon is crossing.
Great.
So 225 non-compliant Q-force. And then we'll come with the other balloon, 2.5, 15. So Bernard, will you do, so we will do a kiss?
Yes.
And then a pot at the end, or?
I think we can perform a new pot.
Okay.
Okay. And for those not familiar with side pots, so just treating the side branch and coming back and potting the main vessel, where are you using that? Is that something that's part of your standard practice?
Not really. So we have tested this approach, and we think that when we have to treat big vessels, it's not optimal. So we do sometimes pot side pots, but when the side branch is really small, so 2.0, no more than that.
Okay.
Because we are not completely sure that at the end the carena will be really in the center.
Yeah.
Which is the most important, because what you want to have at the end is a optimal rheology at the level of bifurcation.
Okay.
So you see now Bernard is adjusting the position of the two balloons.
Yeah.
When you
as
push,
usual, when focusing, when you pull on one, you are pushing at the other.
Exactly.
Yeah.
So I think
it
we have
looks very nice.
which is okay.
Yeah.
On va faire juste un ciné sans angio. I think we are covering the ostium.
Yeah, it's perfect.
Are minimal overlap. I'm relatively happy with this position.
Yeah, perfect.
Are you okay with that, Tom?
Yeah. And so then the strategy will be sequential or combined, or?
Okay. So what we prefer is to do sequential.
Okay.
Because of course we have no clinical proof of that, but some bench data showing that when you do sequential inflation, you have better size of the stent.
Yeah.
So we start with the side branch, then we inflate the main branch, and of course we deflate both at the same time.
Yeah. So as you say, there's some very nice benchtop data by John Ormiston showing that that sequential high pressure inflation in both limbs separately will optimize your expansion of the stent and the side branch. But then importantly, the KISS, as you've said, is about ensuring that you bring the carina back into the midline, I guess.
Yeah, absolutely.
We've got a lot of questions regarding pharmacology, and I don't want to be seen as ignoring them. I think we'll just probably bring the discussion about pharmacology at the end once we've made a final angiographic assessment. So we'll touch upon that in a moment. So what's your next step?
So next step is to look at the result in the side branch, and if we are happy, we'll just do a final pot. Yeah, so Bernard is doing a stent enhancement. I think it's very important. And you will see that now we have a nice scaffolding of the side branch ostium. You see on the image? Not yet. Okay.
Not yet.
Okay, so you can see now that you have really the two sides, proximal and distal, and the scaffolding of side branch ostium. So if you need a stent in the side branch, in this case, I think you will not need to do a tap. Because you have already something which can be perpendicular to the ostium if you put a second stent.
So I mean that's a beautiful demonstration, Thierry. So on that lowest panel, we see how the stent has preferentially been shifted across onto the outer wall of the side branch. Yeah.
So now we'll do the angiogram and then check check if we have to do something at the level of the diagonal or not. But probably it will be okay.
Okay. Hopefully.
Hopefully, yeah.
Un petit décalage en D1 là.
But I think what we have done is just to relocate the carena in the middle, I think.
Yeah.
Yeah.
It looks good.
So maybe can you do more selective now just to check?
Yes. Et on a un sous-décalage en D1 VL. Hein. Test là. Okay. On va faire des nitrates, s'il vous plaît.
Yeah. So we inject some nitrates and then can be the circ.
C'est D1V là. We are going to inject some nitrate. We have a little bit of ST elevation in D1 on VL. So we want to be sure.
Is the patient complaining of any pain?
No.
No.
Okay.
It's been free.
I mean, the difficulty was clearly there was some disease at the ostium of that lesion before even the stenting. So.
Okay. Okay. It's better.
On va enlever les ballons. Il faut enlever les ballons.
You want to make injection, Bernard?
Ouais.
So unless we have reduced flow or evidence of a marked dissection, we're going to be happy, I think, aren't we, to leave this as a provisional approach?
Yeah.
Ok.
Je suis prêt.
On va checker.
Okay. Very nice. Okay, so I think I think the diagonal now is back to what it was at the beginning of the procedure.
Yeah.
Even better. So I think
better, I think, isn't it?
Yeah. So for me, it's okay. Now we have seen that we have very nice deployment of the stent in the LED. So what we can do is to do a final pot.
Okay.
So this is how it was at the beginning.
Yeah, it looks better, doesn't it, really?
And this is now, yeah. Okay, so we can take the 3.0 again, 3.08.
So there's a good question here asking, we've highlighted that the standard would be to use high pressure sequential inflation. There's just one question about whether there'd be concern about high pressure inflation into the side branch and increasing the chance of potential trauma.
Yeah. So this is why we use non-compliant balloons. I think we started doing that more than 10 years ago now, and we realized that by using a non-compliant balloon, you would decrease the risk of dissection and the need for side branch stenting. And you can see in the last view that Bernard has done is very nice. We have very good result at the ostium of the side branch. So we don't go to high pressure. You just go to the pressure to have the correct diameter of the side branch. So in this case, we have it was relatively low, Bernard. So
the pressure on the side branch was 12.
yeah,
Okay, so nominal pressure.
Alone on the side branch. Then we decrease the pressure on the side branch and go to 8 atmospheres on the main branch.
Great.
So 12 atmospheres is very, very reasonable with non-compliant balloon. So it's nominal. Huh? So it's really 2.5.
Yeah.
Sorry, 2.25 for the side branch.
So we have a truly global audience here. So we've had questions from South Korea, India, Lithuania here. We have some more procedural questions. Nitroglycerine, is that your standard? Would you be using that to try and optimize the side branch flow?
Yeah, so we, not for the flow, but for the diameter. So we start with the nitro at the beginning, during the procedure, at the end. We always use nitro.
And from the same participant, there was a question about the wires. So do you have a particular wire preference for your bifurcation treatment?
I think
we use run-through
wire
usually.
Yeah, we use run-through as a workhorse wire.
Yeah.
And this wire is very good for treating the majority of bifurcation lesions.
Okay.
Of course, sometimes you may need different wires like Fiedler FC, for example, or Sion wire, but it's really unusual.
Yeah, so we've already discussed, obviously, the concern that might be had in terms of jailing a side branch wire. But is there any issue in terms of coating, hydrophilic or non-coated wire? Is that another consideration?
Yes.
It was the case in the past. Okay, so now Bernard is doing a final pot.
Great.
Est-ce qu'on peut montrer le stand enhancement?
I think usually for this second pot, we don't go so far. We just
so you see the stand enhancement, so that there is some inhomogeneity of So Bernard is doing the final pot. Maybe you can.
There's a kind of bottleneck effect
16,
at the side of the kissing, so we try to correct. So there is no need to go very distal with this last pot, the deflating.
So now to come back to your question about the wires, it was the case in the past with the Choice PT. Maybe you remember this wire. I think some people are still using it, and with this wire you may have guide wire rupture.
Yeah.
With the wire available today in the market, I think the risk of rupture, coating or not coated or not coated, I think is very low.
Yeah.
So BMW, for example, is coated, but it's very low. I think all the wire usually used in the cornea field are a very low risk of rupture, except if you are gel the wire with 2 or 3 stands, etc. So you think this view, I think, is very nice.
That's a beautiful result.
Yeah. Okay.
I think this is the best we can obtain.
Absolutely. So Bernard, for me, it's perfect. Only one stent in this eye bleeding risk patient is perfect with a stent fully deployed everywhere. So now maybe you can move to the circ. What do you think?
Circ, yes. I think we need to go back to the first.
So Tom, if you agree, we'll move to the circ lesion, which is a little bit more simple.
Okay.
We hope so.
Yeah, of course, it's a circ. So usually the circ increase the difficulty just because you have this angulation between left main and circ, and because there is some calcification.
So I'm just conscious of the fact we have a large number of questions regarding the pharmacological strategy.
Okay, perfect.
I wonder whether while you set up for the circumflex, maybe we could just touch upon master adapt and some other elements, and then maybe come back to you with that. Maybe that would work.
Yeah, it's perfect. Perfect.
Okay. So maybe if we just shift across to the slides momentarily, so I can just briefly run through master adapt. As Thierry has already alluded to, this patient is being considered for the master adapt study. So this is a PI-led, investigator-led study funded by Terumo, and the concept is that it's looking at the management of high bleeding risk patients using the Ultimaster stent, which has a bioresorbable polymer, and using a regime of shortened versus prolonged dual antiplatelet therapy. As I've said, it's an investigator-initiated study, intention to recruit over 4,000 patients across 120 hospitals worldwide, and the patients are deemed high bleeding risk, and I'll highlight what that means. The plan is to compare abbreviated versus prolonged dual antiplatelet therapy. So the study design is obviously to highlight patients at high bleeding risk undergoing percutaneous coronary intervention. They have Ultimaster stents implanted, and actually then there's a 1-month cooling off period, if you like, where patients have been consented for the study, but it's only at 1 month following intervention that they come forward for randomization. And that's really to ensure that the patients retain eligibility. So to be clear that they haven't had either ischemic or significant bleeding events during that 1 month period. And then they are randomized either to an abbreviated DAPT or prolonged DAPT regimen. And what does that mean? Well, it depends a little bit upon whether the patient's on an oral anticoagulant. And so in this example where our patient is already taking apixaban, then if they're on the abbreviated program, the plan would be for them to stop DAPT at 1 month. So at the randomization visit, if they're on the abbreviated arm, they would stop one of their antiplatelet agents, commonly aspirin, and then at 6 months, they would then stop the other antiplatelet agent and actually continue just with oral anticoagulation. In the prolonged arm, dependent on the nature of the patient's presentation, they would continue on the antiplatelet therapy for a further 2 months, so a 3-month total, and then shift across to a single antiplatelet and oral anticoagulant. So what do we mean by high bleeding risk? Well, our patient here today meets the eligibility by virtue of the fact that they're taking an oral anticoagulant. Otherwise, other features are common to many of the high bleeding risk type of studies and registries that have been undertaken, but an awareness of previous bleeding in the last 12 months, an age of over 75, hospitalization from bleeding, a low platelet count less than 100, documented anemia with a hemoglobin less than 11, or chronic use of steroids, non-steroidals are all considered. They also have included the precise DAPT score as another mechanism of assessing patients' bleeding risk, and we may well touch upon that very briefly in our discussions later. So far, this is from the 6th of September, in fact, the recruitment has been really very encouraging, and we're now over 4,000 patients randomized with just over 200 patients remaining. So hopefully we will have some very important results available in just over a year's time. So if we just move back to Thierry and Bernard and see where they're getting to, then perhaps if there's the need for further discussion, we can talk some more during this. Thierry.
Non, c'est bon, là, on a fait 300, on avait 300 ans. Ouais.
So you've wired the circumflex, have you?
Yeah, so
Yes.
Bernard used the run-through again with more angulation in order to access the circ. In fact, the access toward the circ is not so simple because it's coming a little bit perpendicular to the...
It's a very posterior takeoff.
Yeah, absolutely. So it was not so easy. So now we'll do pre-dilatation with a 2.5 8mm balloon, non-compliant again. And so maybe we can show the, well, we have the reference here. Okay, perfect.
So Thierry, I've just outlined the study protocol for Master DAPT. I guess the question, and many of the questions that are coming across from the participants relate actually outside the study. What would you be doing for this gentleman if he wasn't participating in the study? So he came in on apixaban. Presumably you interrupt the apixaban to undertake the procedure.
Yes, but I think now we have really a debate about that.
Okay.
Some people are not stopping the anticoagulation. I think this is, for example, electrophysiologists are doing that,
Right.
despite the fact that they are doing transseptal approach. So I think, yeah, maybe we should move to in this direction in the future. Of course, you have to reduce anticoagulation by heparin during the procedure if the patient is on top of apixaban.
Yeah. Yeah.
And then we'll do give. So, of course, it's a la carte for all patients. So it's not simple. In this particular patient, we'll probably give at least 1 month of triple triple treatment.
Yeah.
With apixaban, reduced dose, and Plavix and aspirin. I would say between 1 and 3 months. Maybe Bernard, what do you think? Outside of the protocol?
I usually use a relatively short.
So 1 month?
Yes.
Yeah.
Short triple therapy approach.
And then the patient will be on the anticoagulation plus Plavix for 6 months, something like that.
And then you'd stop the clopidogrel at 6 months, would you?
Yeah, absolutely.
Okay. So that again is it's controversial, I guess, that as well, isn't it? That some people will be keen to pursue both antiplatelet and anticoagulant therapy for fear of the fact that one is treating the embolic risk of stroke and the other is preventing the stent thrombosis. And are we clear that we're getting cross cover by use of the direct oral anticoagulant?
Yeah.
C'est un 8, c'est ça? Voilà.
C'est un 8, oui. Tu veux un 12, Bernard?
Yes. What do you think, Thierry? We have predilated with 2.58 millimeter IQ force, relatively high pressure, 16, and I suggest to go to 12 in terms of length.
Yeah.
And maybe to consider 275, because it seems
that
I
think it's a good. Yeah.
2.5 is a bit too small.
Yeah, I agree.
Okay, you okay with this approach?
Yeah. So Tom, we plan to use a 2.75 12.
Yeah.
Tu peux avoir un 2,75 de 12 en ultime.
How long is that? How long is that balloon?
The balloon is 8.
8. Okay. I would err on the side of slightly longer, but I know that again you're trying to balance the ongoing stent risk.
Yeah.
But
yeah, absolutely. 15.
15?
Right.
15. Okay.
The circumflex always slightly foreshortens as well, doesn't it?
Yes. So we'll use a 15. Okay.
Yeah, 15.
So we'll sure to have correct scaffolding.
Yes.
So we have in capital letters here, and I promise you this hasn't been a planted question, but why they not use IVUS or OCT? There is some heated passion here that imaging should be at the forefront of this procedure. Why are you not doing this, Thierry and Bernard?
So Bernard, why you are not using OCT or IVUS?
I think clearly it's a matter of medicine and finances. So we are living in a country where there is no reimbursement process for any imaging because the French authority consider that there is no proof of efficacy of intravascular imaging or for using IVUS or using OCT. They consider that the studies are not convincing. So somebody can, of course, have a different view, but this is the view of the French agency.
Yeah.
And we have to play with it.
Yeah. But
we are not alone. If you consider the penetration of IVUS or OCT in Europe, it's extremely low.
Yeah. Even in Poland where they have reimbursement, penetration is very low. But no, Tom, I think our rule in Massy is that if there is something wrong, something we do not understand, we'll do intracorner imaging.
Yeah,
So for sure.
Yeah.
In
But
this
it may be,
case,
as Bernard says, you know, this is evolving, isn't it? And at the present
of
time,
course.
there is not clear-cut evidence to support it. But those people who are using it more frequently become increasingly reliant upon it. And so there isn't evidence yet, but maybe in the future we will be using it before, during, and after, rather than just in response to a problem. But I think it's really important to highlight that there are clear cost time pressures that mean that this is not the routine. As Bernard says, you know, in the UK, only 5% of intervention is done by image guidance. So it would be completely wrong to suggest that this should always be done by imaging, because that is not how it is done in most countries, bar Japan.
And again, I think, of course, with OCT, you clearly see if you have a problem of a position of the stent, etc. But for sizing, I think it's not so simple, even with intracorner imaging.
Yeah.
And we have, maybe you know that, but we have done a study many years ago, which was the BLAST study, which was never published. It was a randomized study with using IVUS versus angiography to guide the treatment of bifurcation lesions.
Okay.
And the study was negative. So clinical outcome was better with angiographic guidance than IVUS. So maybe because sizing was not optimized, despite we had a very good expert on board. So it's not so simple.
It's always a question of systematic strategies.
Never
IVUS versus
absolutely.
Always IVUS.
Yeah, you're right.
I think clearly the truth is probably in the middle.
So now we have, so we went to 12 atmosphere with a 275 2.75 stent, 15 millimeter in length. Bernard will do again the poor IVUS, which is stent enhancement.
I think we've seen it's very effective during this procedure. I have to say, stent vis has been very, very useful.
Okay, so you can see very nicely the stent deployment, which looks very good.
We see also very nicely the calcification.
Yes, of course. And there is some residual waste just at the level of the calcification.
I think we need to use a 275 8 millimeter non-compliant
okay.
I mean, it's interesting, isn't it? Because clearly by angiogram, there is really quite significant calcification in this patient's coronary tree. And we had at the very beginning of our discussion, one of the participants asking about upfront rotablation. It does just go to show how you know, we have to take a sequenced approach and palpating this lesion and assessing whether the vessel will expand before then increasing complexity, increasing the risk to the patient is probably the most appropriate way.
Yeah. So now we, according to the result of the stent enhancement, we'll do post dilatation with a short 2.75 8 millimeter balloon going to high pressure.
So just in terms of the pharmacology, again, I'm sorry, Thierry, to go back to it, but so we've had questions. We've already highlighted you started this patient 10 days before on clopidogrel 75. The patient's on aspirin and apixaban. And in this scenario, once we've completed revasc today, the patient will return in 1 month to be randomized to either a short or prolonged duration therapy. You've highlighted in your standard practice, you would probably continue just for 1 month triple therapy, and then at 6 months consider just going on to apixaban monotherapy. There's a question here asking about, would you consider ticagrelor for any patients? So would you use a more potent P2Y12 in any scenario?
No, we have never done that with the combination of anticoagulation.
Yeah.
Because we have not, I think, enough data about that. So I
No.
don't know what is your experience, Tom.
C'est bon,
So
on verra
we
avec
tend
ça.
not to either, and I think
Yeah.
the difficulty with the, as you say, the data or the experience is that it's very, very limited. So
Yeah.
even Pioneer, Redual, Augustus, they all have probably only 5 or 10% of patients using a more potent P2Y12. So I don't think we can safely say that that combination is a safe one.
Yeah, I agree.
It's interesting. We have, in fact, it's a planted question by one of my old fellows from South Korea. Yongchol Kim asks, should we be using a PRU value? Should we be making an antiplatelet measurement of effectiveness in these patients?
Yeah. So I think this point is very important, and maybe we'll come back at one time. We have done that for many years in our lab, checking that the patient was not resistant or hypersensible to aspirin and thienopyridine. I think we have some very interesting data about that. So this is what we are doing. We are still doing that when we have to stop one of the two antiplatelet treatments. So when we have to stop in a patient with high risk of high ischemic risk, when we have to stop Plavix, for example, we check that the patient is really sensible to aspirin and vice versa.
Great. And you're using Verify Now, are you, for that? Or?
Not Verify Now, but we use multiplate.
Okay. Yeah.
Multiplate. And I think when you look at the data in the literature, the data with multiplate seems to be stronger than with Verify Now.
Yeah.
Okay, so now Bernard has removed the wire from the LED, and we'll do the last
yes. I think
angiogram.
it was important to keep it at least for starting to wire.
Oh yeah, absolutely. I think it was a very important point to have this wire still in the LED in order to have good support when you're going through the circ. Okay, so very nice result. Stent now is very nicely open.
Yes.
There is still something at the level of this big calcification, but I think it's very acceptable.
I think it's acceptable result. We use a 22 atmospheres with a 275.
Looks very good, doesn't it?
Which is the RBP of this balloon. And if we consider the diameter of this balloon, I have many balloons, so I have many of this. Okay, no.
Which one?
It was not good. So we are going to check before removing everything. I plan to use another view just to be sure.
2.9, Bernard, 22.
So it's not so bad.
So 2.75 at 22 atmosphere is 2.93.
Ouais, on va en refaire. Last injection under nitrate.
So we'll show you the last result.
And I think
if this will persuade you, Bernard, you have done such a beautiful job. It was nice to watch and learn from such experts. You have made a complex job easy. A million thanks from Lithuania. So I think you can stop now. Your job is done.
Okay.
Thank you very much for your comment, Tom. You are welcome, and it was nice to have you on board because the discussion was very interesting. Maybe it's time for you to conclude, to continue to answer to some question worldwide.
We can do. Perhaps you want to join me, but really you've succeeded in making a very complex scenario look very straightforward. So Bernard, Thierry, thank you. It's a beautiful demonstration.
Thank you.
Thank you, Tom.
Okay, so if we shift back to the slides, then we've discussed quite a lot across this sort of 80 to 90 minute period, and I hope this encapsulates some of what we've had to discuss, which are that there are really quite complex considerations to take in hand when we're dealing with a patient with high bleeding risk. And And we have this very difficult balance between bleeding and between ischemia or thrombotic risk. So firstly, considering the bleeding, now clearly our patient has high bleeding risk features. So by virtue of being on an oral anticoagulant, being on a Apixaban, that creates greater complexity in our decision making. Is there a role for risk scoring? I in fact undertook a poll on Twitter before commencing today's webinar. I haven't got time probably to show you the results of that, but we had over 125 votes, and it showed quite clearly that the majority use clinical judgment. And in fact, the risk scores we have probably aren't directly addressing the problems we encounter with this type of patient. If we think about the procedural characteristics in terms of bleeding, then clearly the use of transradial access reduces the risk to the patient in the early stages of the procedure, and that was touched upon by Jim Nolan, Jean Fagedet and Bruno Farrar in the first webinar. I'd urge you to go back and watch that if you haven't had an opportunity already. And then in terms of drug choices, we clearly have a huge array of combinations at our disposal. And I think increasingly with the wealth of data we now have from a number of studies looking at the direct oral anticoagulants, we can be confident that using direct oral anticoagulant with dual antiplatelet therapy for a period and then single antiplatelet therapy is probably sensible. I think the jury is still out in terms of duration. And certainly the more contemporary studies, Augustus as an example, demonstrates that maybe only using dual antiplatelet therapy for a week or so may be sufficient, and actually aspirin carries quite significant risk of bleeding. Then in terms of the ischemic considerations, clearly we want to minimize the risk of thrombosis as much as possible for the future, and we saw Bernard do a superb job of limiting the length of stent in the LAD and in the circumflex. The AF clearly poses quite a difficult problem for us in terms of the ongoing thromboembolic potential, but the direct oral anticoagulant helps with that. And then in terms of procedural characteristics, the stent type is going to play a part, and trials like MasterDapt will hopefully influence our future decision making in terms of how we should do this. With kind of specifics regarding the bifurcation, we've seen that taking a provisional simple strategy, really adopting the mantra of the European Bifurcation Club in terms of keeping it safe and simple, we've demonstrated that a provisional strategy is the best. And in terms of drug choices, again, there is this balance between thrombus and bleeding risk, which I've already alluded to. We've got Bernard and Thierry here. In fact, I don't know whether they want to join into the discussion or whether we have any further questions from the floor. But if not, then I think I'd like to return to our original objectives. And I hope you agree that Thierry and Bernard here in Massy have done a fantastic job at basically outlining high bleeding risk characteristics and the role of scoring, the challenges that we face, but really the brilliant way in which we can tackle bifurcation intervention in a high bleeding risk patient. And then we have touched upon and expanded on the difficulties and ultimately the decisions we have to make on treating a patient with atrial fibrillation in the setting of PCI. This is a webinar program supported by Terumo, and I hope you'll join us again in December to meet with Thomas Cuisset, Peter Smits and Marco Valgamigli to talk some more about MasterDapt and the challenges that we face in this very tough environment. Thanks for your time.